So now we will discuss about like any patient which has suspected difficult airway. How will you, because we are discussing the patient groups. Okay, so pregnant patient, what we will be anticipating in pediatric patient, and similarly, we just discuss about a patient who is at risk of embolism and what to do. Okay. So difficult airway. Difficult airway is a combination of difficult mask ventilation, difficult laryngoscopy, and difficult intubation. Actually, these three are a number of time difficult thing, different thing. Okay, like a number of times, maybe laryngoscopy and intubation is not difficult, but mask ventilation is difficult. Like one example is pregnant patient. A number of time you will see that intubation actually is not difficult, but mask ventilation will be very similarly in obese patient. You will see that a number of time you will face this thing, and at the end of the day when you are finally able to have the laryngoscopy, the that intubation is very easy, but mask ventilation was very difficult. So you need to anticipate how, first of all, will be identification. So if patient has any risk factor which are predisposing the patient for difficult intubation, you should be identifying it. Just a second, I will. There was a source by some. It just showed. Okay, so actually there are some among the airway, when because it's very important topic. So you see, I tell you that any risk factor, you just categorize it and deal it separately. Okay, like for example, if a patient is edentulous, if a patient has beard, if a patient has a big neck, a patient has a large breast tissue, if a patient has prominent teeth, okay, if a patient has nasal obstruction, if a patient has a problem in the neck in which you are not able to move the neck, position the neck extension flexion, you are not able to do it. So all these factors might take the patient at risk of difficult mask ventilation. I think there will be uh, certain factors for difficult mask ventilation. Just a second. Oh, I think this is not the, this is the question part. Okay, so mask ventilation, you see, large tongue, epiglottis, tonsillar hyperplasia, history of OSA, edentulous, beard, upper and lower airway tumors, extrinsic compression of airway, foreign bodies, and in these cases you will have problem in the uh, mask ventilation. Okay, either in laryngospasm or bronchospasm, you will also have problem. Okay, high neck circumference, and then these factors like male gender, mask seal with a beard, or see, these are all factors for difficult mask ventilation. Okay, so what factors can help you out? You can do proper oxygenation, pre-oxygenation. And there is another confusion about pre-oxygenation. When we think we are doing pre-oxygenation, we just put the mask and ask the patient to breathe normally. Believe me, it will not cause pre-oxygenation, no matter how much you put it there. You need to ask the patient to have full maximum inspiratory effort and maximum expiratory effort so that all the nitrogen is washed out. Like you can ask the patient to have full vital capacity. Unfortunately, we theoretically we it's written like that, but when we are doing practically, unfortunately, we are not able to do it in a proper way. So make a habit. Any patient you are start to anesthetize. Actually, you can do this practice in all patients. You can ask the patient to have deep breaths, three, four maximum vital capacity breaths. Okay, so it will, and first of all, it will open up the alveoli, which are having atelectasis. Okay, so this will help in your airway management. Plus, if your patient is you are anticipating that maybe there is a difficult mask ventilation, you actually do it in a very proper way so that the apnea time will be increased. You will have more time for apnea. Okay. So, another thing is that proper use of some people will say, because I know that as a matter of fact, if you are not able to ventilate, you should not give muscle relaxant. This is actually one big question mark. But actually, in reality, if you are able to ventilate, maybe use of muscle relaxant, especially if you are using rocuronium with Sugammadex, actually it's better. You can use it and you can reverse it with Sugammadex. But I tell you something, in the exam, you have to be very careful about it. Because in any scenarios, if you think that there is doubt, actual management is awake fiber optic. Actual management is awake fiber optic, but this is actually a practical, more of practical conduct of anesthesia, which we actually do. But for exam, it this if you tell that you give muscle relaxant, actually practically I tell you, it helps in ventilation. But in the exam, you cannot tell because if in exam, if you will tell, any examiner can catch you. So in the exam, never tell to give muscle relaxant, but I'm telling you a practical experience that if you have a 50% doubt and if you make a ramp position and you can try to give muscle relaxant. This is again practical conduct of anesthesia with practical experience. Don't try in the exam because in the exam it will be very difficult for you to defend your words. But this is one option that if you are giving muscle relaxant, it will actually help in ventilating the patient. In light train of anesthesia, sometimes it's difficult. But if you have any doubt, it's better to keep the spontaneous ventilation intact, okay, and inhalational induction. So that will also solve the problem because now the patient is breathing at its own. You don't need to ventilate. The problem occurs when patient is half sleep, half awake. Patient is not breathing itself nicely. You have given propofol and now patient is knocked down. The breathing is knocked down and now you are not able to ventilate properly because of any reason, because of large tongue or large neck, or there are so many factors as we have discussed. So uh, just to summarize, if you have any patient like that, you have to be very careful and don't hesitate to tell about awake fiber optic. Because if you remain safe and you answered in a way that you are able to defend your answer, nobody will fail you. Practical, whatever you do, it's after you pass the exam, do whatever you want. But in the exam, be very careful in answering. Like there was a very senior anesthetist who somehow managed to appear in the final fellowship exam. And he was told by some of his friends that you just have to tell what you do. So he was very confident, and the examiner was trying to take him towards difficult intubation, and he was saying, "No, sir, no problem. I will pass the tube. Sir, don't worry about the tube. I will pass the tube." So such funny incidents also occur that he was not able to understand what they are asking, and he was saying, "No problem, sir. I will intubate the patient. Sir, intubation is not a problem. I will intubate the," because he was a very expert anesthetist and he never faced problem in the airway. But whatsoever is the situation, he is able to pass the tube. But you cannot say this heroic in your exam. In the exam, you have to tell what is safe because such things are never safe. Okay, so this is few words about it. So there will be some factors in the history, there will be some factor in the examination, as we all do these, all the malam pattis and this yeah one this thyromental distance. I think it will be downstairs here. Uh, just a second, please. This Lemon Law and Wilson score. Okay, all these things you will be doing according to the situation. If it is thyroid, you will be also looking at the tracheal deviation, which you will be finding through X-ray. You will be seeing the tracheal compression to rule out tracheomalacia, postoperative tracheomalacia. That will be through lateral neck X-ray. You will be looking at the retrosternal extension of thyroid. So this will be another extra thing. Okay, and you will be anticipating. You should have in this scenario where you are expecting that airway can collapse when you are inducing the patient. Okay, either you go for awake fiber optic, or you can say that I will try to have inhalational reduction with preservation of spontaneous ventilation and with ENT on board with presence of rigid bronchoscope. Okay, so in case the airway is collapsing, you can use rigid bronchoscope to ventilate the patient. Or another thing which you can do is reverse Salic maneuver. Reverse Salic maneuver is the one in which you lift the thyroid tissue, and in the neck swelling you lift it, just like in this uh, Salic maneuver is pressing the cricoid cartilage. The reverse Salic maneuver is lifting. Or another thing in that scenario in which you are heading towards cannot intubate, cannot ventilate scenario. In this scenario, maybe one option is this reverse Salic maneuver. One option is rigid bronchoscope, or another option is to tell the patient towards the side. So it will also it can relieve the obst compression of the trachea. So, but safe answer is awake fiber. So any condition like that, you will say awake fiber. Then other, if there is any problem with the like trachea is deviated, or there is preoperative involvement of recurrent laryngeal nerve with the hoarseness, or one side vocal cord, so you will be anticipating it, you will be documenting it, you will be doing nase endoscopy in that scenarios. So like I'm just summarizing what I have told up till now, that identifying the problem through history examination and relevant investigation. Okay, like all things are there. There will be some tests, some physical examination tests, some radiological examination, some history, and then you will be identifying which patient is at risk. Okay, like they have all mentioned it here in this. It's compiled on my request. Only one candidate did it many years ago. She has already passed FCPS. I gave her the question and he found out the question and we compiled this source. So CT scan, sleep studies, flow volume loops, ABGs for respiratory distress, and then you will be following the difficult airway algorithm. So in difficult airway algorithm, remember one thing, that few things should be in your mind, anticipated and unanticipated. Then you have presence of different laryngoscopes, video laryngoscope or McCoy or lidoscope, or like you can use in if you are failed with laryngoscopy, you can use intubating LMA through which you can try to intubate you, or you can any surgery which can be done in supraglottic airway device, you might proceed with it, especially emergency surgery. Otherwise, if it is an elective surgery and you are not able to ventilate your endotracheal tube, actually you will awake the patient. So you will be following the difficult airway society algorithm. But usually that if you are not able to ventilate, or if you are not able to intubate, you have to follow the DAS algorithm. Okay, LMA or supraglottic airway device, oropharyngeal airway, or any nasopharyngeal airway will be helping you out. Making RAM position will be helping you out. Suctioning and like repositioning, bringing the patient near to you. RAM position, as I mentioned, in which the external auditory meatus is lifted to up to the angle of this sternomental, sternomandible. What I'm sorry, what's said? This angle of Louis. Okay, this sternomental, manubrium sterni, and sternum angle. So you lift the head in that way, in which you put there is special Oxford pillow. So rapid airway management position is one of the rescue. Okay, because it will reduce the pressure on the lungs, FRC will be increased. And actually, another advantage is that whenever you have a patient has risk of aspiration alongside difficult intubation, that condition is there in obesity or pregnant patient. Actually, when it is upside, so uphill against gravity, the pressure should be generated so that the gastric content will be moving uphill against the gravity to cause aspiration. So it's a prevention in that way as well. So okay, you see that they will optimize head and neck position, pre-oxygenate, adequate neuromuscular blockade, direct laryngoscopy, external this burp maneuver. Okay, backward, upward, rightward pressure, and use of bougies, stillate. Sometimes you see remove required pressure. Required pressure is sometimes creating more disadvantage than any advantage. Okay. Mm. In pregnant patient, there is a little different because you will be uh, taking care, you will be identifying according to the um, emergency surgery. Okay. You will be taking care of, like if it is emergency surgery, you might need to proceed even with supraglottic airway devices. So I think these are enough for this topic. Let me see what other questions you need to know. Mm, okay, so I think that's enough for this topic. And